Delighted to introduce Dr. Bozkurt to you. She received her MD from the University of Istanbul, completed a residency in internal medicine as well as a chief residency and a general cardiology fellowship at Baylor College of Medicine in Houston. Then went to Pitt to complete a fellowship in heart failure and cardiac transplantation. And in 1997, returned back to Houston to join the faculty at Baylor as an assistant professor, rose through the ranks in 2003, was promoted to associate, and in 2008, full professor with tenure. She currently has a long list of titles, some of which include professor of medicine and molecular physiology and biophysics at Baylor. She's vice chair of the Department of Medicine, associate director of the Cardiovascular Research Institute, and director of the Winters Center for Heart Failure Research at Baylor College of Medicine. In her spare time, she works at the VA, where she is chief of the cardiology section, chief of the medical service at the Michael DeBakey VA Medical Center in Houston. She also holds two endowed chairs, the Mary and Gordon Kane Chair of Internal Medicine and the Tex and Deborah Moncrief Chair at Baylor. Dr. Bozkurt is well recognized as a national expert in heart failure. She's published more than 130 peer-reviewed publications in this area. She's also contributed in a major way to national guidelines in heart failure management. Her own research interests over the years have included studies on the mechanisms of beta blocker therapy and LV functional improvement, the roles of cytokines, inflammation, and metabolism in heart failure, as well as studies on biomarkers in heart failure. Her clinical research laboratory has been supported by funding from the NIH, the VA, as well as industry. And in her current role as Associate Director of the CVRI, she manages a portfolio of about $6 million in grant funding. In addition, Dr. Bozkurt is recognized as an outstanding clinician, educator, and mentor. She has mentored more than 30 trainees over the years, and she's received a long list, more than a page long, of teaching awards and master clinician awards from Baylor, as well as from the Secretary of Veterans Affairs and the American College of Cardiology. Delighted to have you here today to speak on the topic of neprilysin inhibitors, the science, mechanism, evidence, and unanswered questions. Dr. Bozkurt.
Thank you. Well, I'd like to thank Dr. Igarashi for that glowing introduction. First and foremost, I really value the team over here. Quite a few of you, Dr. Gary Francis, have been role models, mentors, and truly beacon of light for me through the years. I'm a heart failure transplant physician and thus know the legacy. And I also value transformative leaders as well as dedicated mentors and educators. So I've been lucky and privileged. I've been in your shoes not long time ago and have been in a really good incubator to be able to do the things I have passion for. The topic I'm going to present partly was a collaborative decision with Dr. Francis, is one of those most recently, I would say, topics that is covered in cardiology a lot. I don't want to say contentious, I want to say focused attention, because it's potentially a paradigm-changing treatment strategy. But the first disclaimer I'm going to quote is, I do not like doing new product discussions. So this is not a marketing talk, and that's certainly not who we are as academic cardiologists. And being in the guidelines and my position, I have to really take a very careful stance in putting the science behind this. And the rigor we need to introduce to any new agents requires for us to look at this thoroughly. So I try to, from a humble perspective, look at what's out there. This is not a reflective of my own science, but at least with the binoculars as a clinician, as a clinical investigator, as a translational scientist, I try to look at the spectrum to understand exactly the current platform by which this could be an implementation in our clinical venue. So the topic is neprilysin inhibitors. And I will try to walk you through the background, and that may take about 10 minutes for us, so bear with me. I do not have a conflict of interest other than to state that I did participate in some of the early clinical trials as a co-investigator or as a PI. So that, in essence, is perhaps a conflict that we quote in AHA-ACC, but I do not have any sponsor activities or not direct support from the sponsors. So starting with the experimental background, neprilysin is an interesting peptidase. It is a membrane-bound, metallic, zinc-dependent endopeptidase. And it's also interesting in the sense that it is transported to the cell surface, and thus is called as a membrane-bound but ectodomain present enzyme, and bulk of its structure is facing the extracellular space. The other interesting thing through this journey that I stumbled into is this is the importance of multidisciplinary collaborative research. This perhaps peptidase have been defined by numerous different disciplines with different names, and it's the same thing. And thus, as I try to show you the data, you will recognize the neutral endopeptidase. We call it neprilysin, which is the same thing as CD10, which is the same thing as the acute lymphoblastic leukemia antigen. So if there are any hematologists in the audience, they will say, oh boy, we've been using this for a long time. You guys cardiologists stumbled onto this late. The answer is yes. And I will also show the nephrologists were the first who defined this endopeptidase. It's an oligopeptidase. It cleaves peptides that are 40 to 50 amino acids, not the huge bulky stuff. But this is a busy slide, just to show you the wide spectrum of substrates that it can cleave. And that goes from entities such as andromegeline, which is a vasodilator, amyloid beta peptides implicated in Alzheimer's disease, angiotensin 1 and 2, which is our bad players in cardiology in both hypertension, CAD, and heart failure. Bradykinin, vasodilator, but also implicated in angioneuritic edema. A variety of endorphins, enkephalins, which play a role in pain and also perhaps the central nervous system. Endothelin-1, which is very important in terms of vasoconstriction and pulmonary hypertension. Also natriuretic peptides, and we'll go over that in a minute. And substance P and VIP and glucagon. So it is a wide spectrum of substrates, so it's not one. And as such, there would be relevant of agents to cardiology, but not to undermine the role of others. So we need to be very, very respectful for the wide spectrum. So this is an old paper. I had to get it from the paper version from 1973. It was first described by nephrologists as a neutral proteinase in both rat kidneys as well as rabbit kidneys. And they noted that it was hydrolyzing insulin B chain and glucagon. And this was in 1973. A couple of years later, it was rediscovered by the neurologist, this time as a brain enzyme responsible for inactivation of the enkephalin. So it was given the name enkephalinase. And 10 years later, neurologists noted that not only is it breaking down enkephalin, but also substance P, which is implicated in pain stimulation and or sensorium. And thus, they said, this doesn't appear to be specific to enkephalin, so let's call it endopeptidase. I did mention to you the hematology, identifying this as perhaps a pathognomonic feature for the pre-B cell type ALL, and now they're using it as a diagnostic marker, which is present in approximately 85% of the ALL cases, but also as a prognosticator in a variety of cancers as a cell marker for CD10. So it's implicated in adenoid cancer, testicular, breast. There is a variety of publications that's coming up, and this has been pretty much a rapidly evolving field in cancer in the last 10 years. I also stumbled into this. which I'm not so sure the different disciplines are talking to each other. So it's now identical to the skin fibroblast elastase, which is implicated in wrinkling and UV damage. And dermatologists are focusing on inhibitors as topical agents to prevent wrinkling. And they were able to show very elegantly that immunostaining definitely homes the NEP antibody to the skin. And as with aging, the levels rise. So very interesting spectrum of scientific evidence from the white substrate targeting of neprilysin. So the spectrum is wide. So it could be prognostic, diagnostic, maybe pathogen in Alzheimer's if it were not to be there, and also implicated in the neurohormonal network with a lot of neurohormonal breakdown. If we look at the knockout models, which are used as evidence or implicated in sort of mechanisms, the NEP knockout mice are actually hypotensive. They have a blood pressure that's 20% lower than the control group. And also, they're very prone to septic shock. If you were to give them endotoxin, they leak. Their post-capillary leak is very pronounced. So that's probably due to neprilysin's role in activation of substance P or bradykinin. So in the knockout, when that breakdown doesn't happen, the substance P and bradykinin has been implicated with levels as a role for this. NEP knockout mice also tend to be obese, metabolically deranged, they're insulin resistant. Even if you were to feed them low-fat diets, they gain weight. And it's a late entity. It's usually seen 6 to 7 months of age of mice. So it's a late onset obesity, which is similar to our perhaps phenotype in the human epidemiology. But it's an interesting concept to figure out. So it's a long-term exposure of lack of NET that may be associated with changes in HDL, VLDL, triglycerides level, and glucose. And also it affects behavior. I did show you the initial sort of concepts about amyloid beta, but NEP knockout mice also tend to show some behavioral changes. They tend to be a little bit more aggressive. They drink more alcohol. I didn't realize there were that much research on alcohol habits of mice. They eat a lot, that I was aware of, but they have stress-induced increased alcohol consumption, and they have increased or exaggerated pulmonary vascular remodeling. So this is the data about the knockouts with NEP. Now, the beta amyloid story is very interesting because that's one of the areas that everybody is right now very, very concerned about. As I showed you that NEP is an important amyloid beta degrading enzyme. And there is data that in the NEP knockout mice, the accumulation is more pronounced. NEP inhibitors increase the beta amyloid levels. And there is actually a mouse model, this 5XFAD mouse, that's an early onset Alzheimer's model. And they do have plaques. By crossing that mice with NEP knockout mice, one can accelerate the model. And if you were to give overexpression of NEP to that model, then it is abrogated. So there's definitely the positive control, the negative control, and this concept appears to definitely, from all aspects, be a significant finding. And the gene transfer to that mouse model was able to reverse. But there appears to be a predisposition of the tangle presence or some kind of a phenotypic presence for this concept to be attenuated, not de novo normal mice. There's also a story about macular degeneration. The amyloid beta peptide can also be implicated in the age-related macular degeneration. It needs to be aged background. And the NEP deficient mice developed the retinal pigment epithelial cell degeneration, and intravitreal administration of the recombinant form of NEP actually decreases the amyloid beta deposition. Now, I showed you the experimental data and the knockout. Now the functionality or the activity of NEP. I mentioned to you that it's a metalloproteinase. It has a domain that binds zinc, magnesium, I'm sorry, as well as zinc. So in this sense, in the hypomagnesiemic mice that are very deficient over a long period of time, the NEP activity, neprilysin activity goes down. And this is the immunohistochemical staining as well as the fluorescence by pixels. It's important for the heart failure docs because we tend to have a lot of iatrogenic hypomagnesemia, which then may create the issue of, does this perhaps neprilysin function not only be affected by treatment or medications, but a variety of other things, such as, so far from the neurology literature, we know that aging, ischemia, hypoxia actually reduce the neprilysin activity. We now know from heart failure literature that if the patient is sick and has elevated substrate, such as BNP, there's too much of it, then the activity, as in every enzyme, tends to be downregulated. Antioxidants, some deacetylases, tyrosine kinase inhibitors tend to sometimes augment its activity. So it's functionally modifiable dependent on the epigenetic as well as environmental factors. So the neprilysin inhibition came as a potential target, especially because of the neurohormones that it was implicated in that were beneficial, such as natriuretic peptides. So if we were to inhibit the neprilysin, perhaps we could increase the natriuretic peptide levels. That was one of the perhaps beneficial ones, which I tried to color in blue. I don't know whether you're able to see it from back. But there are other entities, such as NEP inhibition, which breaks down these things, may potentially create increased detrimental levels, such as angiotensin 1 and 2, or amyloid beta peptides, endothelin 1. Bradykinin can be dual. Too much of that could be good for vasoconstriction, meaning vasodilatory role may be beneficial and maybe one of the mechanisms by which ACE inhibitors work, but we also don't like it in angioedema. So early neprilysin inhibitors had limitations because of low potency, they were short acting, and they had very limited bioavailability. I'm not going to bore you with this, but they did not necessarily result in even experimental data. A few agents had some bimodal effects. There was a coronary ligation study, which is represented on the right side of each graph, with the sham on the left side, showing the ANP levels were able to be demonstrated. Both ANP and the BNP levels were able to be demonstrated to be upregulated with a NEP inhibition with one dose in the acute model. But when given chronically, they couldn't sustain the elevation of the ANP and BNP, is what we wanted. So these are important things for us to be aware of. Looking at early clinical studies with neprilysin inhibition from the cardiovascular perspective, the initial studies, and we're talking about neprilysin inhibition alone. We're not so far combining it with ACE inhibitors or angiotensin receptor blockers. So NEP inhibition alone was tested, and this is a representation of an early clinical study, phase 2 study in a small population, demonstrating improvement with NEP inhibition, which is represented by this square line on top, captopril on the second line, and control group on the third line, showing improvement. Everybody had improvement in their exercise time, but not a significant difference from ACE inhibitors. NEP inhibition alone had mixed results in the cardiovascular venue. It actually resulted in acceleration of hypertension, some deaths in certain studies, and aplastic anemia. And when we looked at their biomarker profile, endothelin levels as well as Ang1, angiotensin 1 and 2 levels were elevated. And that was the reason behind the potential, perhaps mixed results. There were also studies showing improvement in cardiac output, reduction in wedge. So the acute increases in the natriuretic peptides are potentially resulting in improved loading of the heart, improving cardiac output, but there's also the signal of increased angiotensin 1 and 2 and endothelin, and which were demonstrated in the clinical studies. Thus, neprilysin inhibition by itself may create this duality or a delicate balance where you have the vasodilatory, from the cardiovascular perspective, of a beneficial role of increasing, augmenting natriuretic peptides, maybe to a certain extent bradykinin, adrenaline, and then you have the opposing role of increasing the angiotensin 1, 2, and endothelin. So the concept was, how can we perhaps have this and also block the RAS? And thus, the concept of neprilysin inhibition and combination with RAS inhibition came along. And the first concept everybody thought of was, of course, combining it with ACE, which would, NEP, as we had mentioned, breaks down both angiotensin 1 and 2. NEP inhibitor will elevate these. But if we were to give the angiotensin converting enzyme inhibitor, I think I'm touching the screen too much, or coming close to it, then the angiotensin 1 conversion to 2 would be blocked. So we would be able to eliminate all the adverse outcomes of perhaps RAS and augment the beneficial aspects of the natriuretic peptides. So there were 3 agents that combined ACE inhibitors with neprilysin inhibitors, and the prototype of that was omapatrilat, which was studied widely in hypertension and heart failure, which I'm going to talk about. And the early studies with omapatrilat against ACE inhibition. So omapatrilat is ACE inhibitor with NEP inhibitor. When compared against ACE inhibitor, was more potent in reducing blood pressure in hypertensive individuals. Over here, we see the systolic, diastolic, and the mean results in the omapatrilat group, which is in the black bars. And it was a single dose compared against about optimal dose of lisinopril, still was much more potent in reducing blood pressure. In the animal models, hemodynamic data was favorable. Cardiac output was improved, EDP was reduced. There was even evidence of reverse remodeling, and there was evidence of diuresis, natriuresis. So overall, the whole spectrum, both from the hemodynamic and the blood pressure perspective, looked very favorable. And from the cellular and reverse remodeling perspective, there was even evidence of reduced myocardial fibrosis and prevention of maladaptive hypertrophy. Looking at the early clinical studies, this was the first study, the IMPRESS trial, with 573 patients with a 12-week administration of lisinopril versus omapatrilat. Overall, there was a lower combined endpoint in the omapatrilat, which was mortality along with heart failure readmissions and or discontinuation of medications due to worsening of heart failure. But there were more adverse outcomes in the omapatrilat group due to angioneuritic edema. If we were to look at their ANP and BNP levels were increased in the omapatrilat group. Their Ang2 and endothelin levels compared against lisinopril alone were comparable. So in summary, after the ACE and NEP inhibition in hypertension and heart failure groups, we had some favorable hemodynamic and good morbidity and maybe an inclination for combined endpoint benefit, lower levels of Ang2 and ALDO in the preclinical models, increased levels of natriuretic peptides and bradykinin. When we moved on to the large studies, this is Overture trial, which was a large scale, over 5,000 patients with omapatrilat compared against enalapril at 10 milligram BID dose. And omapatrilat in this study was given as a single dose, 40 milligrams once a day. it was a study that was looking at non-inferiority. And the study fulfilled its demonstration of non-inferiority. It didn't show superiority of omeprazole, but there was a trend for increased angioedema, 24 versus 14, which didn't reach significance. There was more hypotension, less renal impairment with omeprazole. The interesting signal that was noted was blacks had a trend for increased adverse or risk, and those who were hypertensive had the highest benefit. That was, right now in hindsight, is an important perhaps subgroup analysis. The second large-scale trial is a hypertension trial called the Octave trial, which looked at role of omeprazole again against enalapril. And omeprazole, which is represented by the dark bars, was more potent in achieving target blood pressure, which was less than 140/90. But this time, there was truly a clear signal of increased angioedema, almost double or triple rate. And two of the individuals required intubation and with the angioedema, so it was quite severe. With this data, with the culmination of the meta-analyses, angioedema risk actually compelled the FDA to reject the drug application for omeprazole. Therefore, it was taken off the shelf. After that story, NEP inhibition alone, we said, is bimodal in terms of its effect because of the increased effects perhaps in the vasoconstriction profile. NEP inhibition with ACE inhibition because of angioedema is potentially dangerous. So then came the concept of why don't we look at NEP inhibition with angiotensin receptor blockade? The reason that both of these would be implicated in more angioedema than this, ACE also is breaking down bradykinin. Therefore, ACE inhibition will elevate bradykinin, so we would have a double augmentation of the bradykinin effect. And the hypothesized mechanisms for the combined neprilysin inhibitor and ARBs include augmentation of the favorable nephrotic peptides and blocking the angiotensin receptor at the AT1 level. Now, things to perhaps focus on over here, the agent that has been studied widely in the heart failure venue is a combination of sacubitril and valsartan. Sacubitril actually inhibits the neprilysin. Neprilysin breaks down BNP. And if we look at the BNP, the precursor is pro-BNP, which is cleaved into two fragments, the anti-pro-BNP, which is the inactive fragment, and the active fragment is BNP. We measure both in clinical venue. Both have been validated as a diagnostic and prognostic marker. But one needs to keep in mind, neprilysin actually breaks down BNP, doesn't touch anti-pro-BNP. NEP inhibitors increase BNP levels, doesn't affect anti-pro-BNP levels. So in the clinical paradigm, if one were to use these biomarkers, one needs to be aware which is an effect of the drug versus treatment effect. Early studies with ARNI, which is angiotensin receptor blockade with neprilysin inhibitors. This is a rat model. And looking at the neonatal rat cardiomyocytes, the hypertrophy was reduced with the NEP inhibition along with the ARB use. The cardiac fibroblast collagen synthesis was down. And in the total hearts, the overall remodeling had signaling for a better, perhaps favorable reverse remodeling. So the experimental models were favorable. This is a busy slide. Just as a comparator, I will try to walk you through these. These are early studies. Quite a few of them came back to back. The first two were in hypertension studies. Some looked at the combo of ARNI against ARB. Some looked at ARNI against placebo. So this is a hypertension study, not heart failure. And then we had the heart failure with preserved EF early study with the Paramount study, which was ARNI, the combined NEP inhibitor with the ARB against valsartan. All of them had very favorable results. The hypertension had favorable results on hypertension. They reduced the blood pressure. There was no angioedema. So the safety signal was good with the ARNIs. And the blood pressure lowering profile in hypertension was good. In the HEP test, the overall clinical endpoints are very difficult to demonstrate, but they did show that the NT-proBNP was reduced, as well as the systolic blood pressure, and there were some effects on the left atrial size, reduction in left atrial size, but not on the LV remodeling. Looking at large-scale studies, Paradigm Heart Failure is truly the landmark trial. It's enrolled more than 8,400 patients, looked at the role of the combined NEP inhibitor, which is sacubitril against, with valsartan, against enalapril. And enalapril dose was 10 milligrams twice a day, and the ARNI was given as a 200 milligrams twice daily. Was published about almost 2 years ago now, and it's enrolled patients that are class 2 to 4. Ejection fraction was less than 40 in the midst of the trial because of the emphasis trial results coming, showing a new, perhaps a treatment modality needing to be incorporated that may change the outcomes. And the sample size, they reduced the EF down to less than 35. And they had to be on background therapy. Now I'm going to spend a minute over here. The titration of this agent in the trial was quite, I think, well designed, but has quite a few details for us to be aware of. So the patients had to be on a modest, good, stable dose of enalapril or equivalent at the dose of minimum 10 milligrams per day. And they had to be at the screening normotensive with a blood pressure greater than 95. And during the run-in period, they were placed on 10 milligrams of BID of enalapril for 2 weeks and had to tolerate that. If they tolerated, they moved into the second run-in, okay, this time with the ARNI, first starting with the 100 milligram BID, then escalating into the 200 milligram BID dose. If they tolerated, then were then randomized. So it's a run-in period of definitely demonstrating perhaps tolerability and selecting the individuals who can tolerate and then randomizing them. And the mean dose on the ARNI was quite good, 375. Mean dose of enalapril, people debate this a lot, was 18.9 for a 10 BID dose. It's a good dose. And as a reference, whether that's a relevant dose in terms of the background therapy, in the SOL trial, the enalapril dose was 16.6, and in the consensus was 18.4. So in essence, in terms of our evidence, our only mortality evidence is from these two trials, it's actually equivalent in terms of the enalapril dose. The perhaps generalizability to certain populations, the blacks comprise only 5% of the population. I showed you from the Overture data that they're more prone to angioedema and are definitely at a higher risk for the safety concerns, and the representation was about 5%, so not a large group. And there weren't many NYHA class 4 patients. The majority of these patients were class 2, combined with 1 is about 75%. So sick patients are not necessarily there. And majority were hypertensive with history. They were on a good background therapy, but the ICD used, this was a study, the major recruitment, 2/3 of the recruitment was from Europe. And ICD intake is lower there, was only 15%. So one can make an argument whether, you know, that represented a good standard background therapy. The EF, the mean EF was definitely less than 30%. And then majority were on ACE inhibitors or ARBs as the trial required. It was a very robust study that demonstrated hard endpoint benefit. And this is the primary endpoint, which is a combined endpoint of cardiovascular death and heart failure hospitalization, which is significantly reduced by an order of risk reduction, the order of 20%. The other thing that the trialist always emphasizes is the p-value. I don't usually put a p-value to this level, but of course the trialists, the clinical scientist training program may emphasize this. Being less than the 0.001 level actually creates a recognition that the likelihood of this being replicated by a second trial is quite high. And some people try to make this as an argument for a justification for only one study is adequate enough. But I'm going to leave it at there and not make any further comments. But looking at each endpoint, the cardiovascular death was also reduced in a similar extent, 20% risk reduction with a similar highly significant p-value with the ARNI treatment against enalapril. And all-cause mortality about 16% risk reduction, again, with ARNI against enalapril. And the heart failure hospitalization is quite robust, about 23% risk reduction, and again, with a significant p-value. When we look at post hoc subgroup analysis of who benefited and who did not, and I think because of the smaller representation from African Americans, the confidence intervals crossed the line of unity, therefore they couldn't demonstrate benefit in blacks, but of course that's a subgroup analysis. And less sick patients, class 1 and 2 benefited, the class 3 and 4 for the primary endpoint crossed the line of unity. So these are the things to keep in mind. And individuals with very low EF, less than 35, significantly benefited. Over 35%, which is 1/3 of the population, it crossed the line of unity. So the lower the EF, the higher the benefit is. And those individuals who were not priorly treated with ACE inhibitors, for both endpoints did not reach significance. So patients had to, or in essence, by the post-hoc analysis, patients who were treated with ACE inhibitors in the background therapy are the ones who conferred the benefit. Safety. Interesting nuances here. It causes hypotension more than enalapril. So the ARNI is a potent antihypertensive agent. We need to keep that in mind. And I think the titration and which patients will be able to tolerate this will be important. Hyperkalemia and AKI, or worsening of renal function, is less with the ARNIs compared to the enalapril at that dose. And cough was less than ACE inhibitor. And angioedema didn't reach significance, but numerically, the trend was higher, as was the serious ones, didn't reach significance, and the investigators definitely emphasized that. But of course, this was important. In terms of the biomarkers, I did mention this. I don't want to go through the busy slide. This is the profile of what happened. The NT-terminal proBNP, which I had mentioned to you, is not increased due to the NEP inhibition. Was reduced because the patients got better. So that was actually correlated with the diuresis and the weight loss. And there was also an increase in cyclic GMP in the urine. But the NT-proBNP levels were reduced, which are represented by the white circles and the white bars, the ARNI group. And the enalapril group is the dark ones. ANP and the C-type natriuretic peptides were actually increased. And that's a reflection of the biological activity of the NEP inhibition. So you are seeing the difference in the ARNI groups represented by the white bars at the end of the trial after the randomization were higher than the enalapril group. So that perhaps divergent trends in BNP versus NT-proBNP needs to be recognized by the clinicians. And this was also seen in the HFpEF trial, that in the Paramount trial, the NT-proBNP levels were reduced, but the BNP levels were increased. Now, the dose in the study, the ARB dose, angiotensin receptor blocker dose, valsartan dose is different because the formulation is different than what was used in the past. So the 103 milligrams of valsartan in the 200 milligram combined dose is equal to the 160 milligram of the valsartan, which was the dose that was used in the VALHAV trial. So it's equivalent to the beneficial valsartan or evidence-based valsartan dose. And it is to be given twice daily because from the hypertension trials, when given once a day, especially with the omaveloxolone, it was noted that the levels could not, or the efficacy could not be sustained for the whole day. So from that experience, they knew it needed to be given twice daily. And the 97 milligram of the sacubitril, 103 is valsartan, 97 is sacubitril, which is the NEP inhibitor, makes a total dose of 200 milligrams, actually provides 90% NEP inhibition. So that's how the magical dose came up with the BID dosing. But the thing to be aware as clinicians is the product now is available in 2 other doses, lower doses. And one will need to be aware of that they have not been tried in the trial background other than the initial run-in period. The enalapril dose we talked about was equivalent to what was in consensus and SOLVE. In other trials with the forced titration of enalapril, such as Carmen and CBIS-3, the average dose achieved was 15. So I tried to survey the whole spectrum of what is the optimal enalapril dose, because I usually have difficulty up titrating to the 20 BID dose. That was the aspirational goal in the SOLVE and the consensus. So the 10 BID is maybe a more realistic dose than what was achieved. So that's what most of our European colleagues will state when they say, okay, was the comparison group designed in a way to make the ARNI look better? Perhaps, but at least that's what the reality on the ground is. 12% of the patients did not complete the run-in period. So this is an interesting randomization, post-tolerant group that was able to tolerate it. Now, there are now a variety of post-hoc analyses that are coming out. Some of these are addressing these questions that we're posing as clinicians. How safe is this? How good is this? So, and whether the enalapril dose was underdosed. So reduced dose of ARNI comparison against reduced of ACE inhibition. That was a Journal of Cardiac Failure publication as part of the HFSA annual scientific sessions, which showed even at the lower doses, the ARNI was favorable. And as it currently stands in our building blocks of where to put the ARNI is a very important discussion. And I know the guidelines groups, both at the ESC, AHA, ACC, are addressing this concept, whether it will need to be implemented for individuals who are tolerating the ACE inhibitors and ARBs and replacement versus de novo initiation for those ones who are not on it or those who are intolerant. So that discussion is holding place. And the concept of, well, it was never compared against placebo because it was not ethical, because we do know that ACE and ARBs, ACE inhibition and ARBs work in heart failure. Dr. McMurray and his colleagues actually did a very interesting, for those ones who are interested in clinical trial designs, they did a putative comparison analysis that got published in European Cardiac Heart Journal of comparison of this trial's active arms against the SOLVE placebo as well as CHARM placebo, demonstrating that the ARNI treatment, when compared against the placebo arms of other studies, are significantly beneficial for all outcomes. And with this, immediately after this, the Canadian group actually modified their guidelines. And they put a very bold, I would say, statement saying patients with mild to moderate heart failure, which is the majority of the patients, 75% of the patients, low EF, elevated natriuretic peptide or hospitalization, which was in the inclusion criteria, good kidney function, with good background therapy, should be, they say, they use the terminology of should be considered for switch over to ARNI. What does the package insert say? Because I always get worried about what the company suddenly puts as safeguards. So they have a variety of things over there that we need to be aware of. So first of all, ARNI, ARB, along with NEP inhibition, should not be given at the same time with ACE inhibition, right? angioedema risk is going to be tremendous, and it's going to be what we call the triple therapy, the hyperkalemia, the acute kidney injury risk is going to be quite high. And of course, it should not be given with potassium-sparing agents, and we need to be worried about with the type 4 RTAs and the diabetes. And then interesting, lithium toxicity has occurred in certain patients. Now they have this recommended starting dose is the 100 milligram dose, the combo of 49 plus 51. So the company says, start the low dose, because that's what the run-in period was, and double the dose after 2 to 4 weeks, and try to achieve the target dose of 200 twice. And they also recommend, if you're going to switch from ACE inhibition, to stop the ACE inhibitors 3 days before. In the trial, they allowed discontinuation 1 day before, but you need to have a washout of 1 day. And they actually wanted a dose adjustment for eGFR less than 30, and they want 50 milligram dose. So for CKD, very advanced CKD patients, they actually want a dose adjustment, even though the study with post-analysis did not state that. So there probably is more data that we need to hear about. And the dose should be doubled as tolerated and not recommended in patients with severe hepatic abnormalities. So in the final 2 slides, I'll try to go over the unanswered questions or the challenges. There is one interesting study that just came out in JACC heart failure. In sick patients with acute heart failure, when the immunoreactive, meaning the BNP plus the anti-proBNP levels were more than 900, the neprilysin activity was downregulated. So these individuals didn't have high NEP levels to start with. And thus, sicker patients may have a different response. Remember, the benefit was shown in this trial, and majority of the patients were mild to moderately sick. So as to how the generalizability is going to be for a perhaps a much sicker population, where the antihypertensive effects may be much more than natriuretic peptide effects, probably will need to be taken into consideration. The other, I think, response the investigators did is looking at risk, other than NYHA classification. This is a busy slide. They utilized 2 risk scores, MAGIC risk score and the emphasis heart failure risk score, and they categorized them according to quintiles and quartiles. And the higher the risk the quintile was, okay, let's try. The higher the risk still was the persistent benefit of the ARNI, which is represented by the blue line, compared against enalapril. So their perhaps defense or their explanation was across the whole risk spectrum, regardless of the risk scores, the decrement or the benefit, the endpoint benefit is similar. And they did even a trend analysis. This is another post-hoc analysis of age spectrum. This is the x-axis is the aged years going from 20 all the way above 90, and looking at the hazard ratio, plotting the hazard ratio for each endpoint. This first one is the primary combined endpoint of cardiovascular death and heart failure hospitalization. Cardiovascular death, heart failure hospitalization, all-cause mortality. 2 of these at really advanced age, over age 80, cross over 1, meaning potential risk, but they do state that the interaction analysis was not significant. Thus, unless the interaction analysis is significant, you shouldn't do a subgroup analysis for age over 80 or 85. So this is just a trend. The confidence intervals are quite wide, which is represented by the shades. But again, the generalizability to individuals that we didn't test in the trial, as is the case with any agent, including ARBs or ACE inhibitors, probably is an important concept. This is a study about the spectrum of benefit with the EF. I mentioned to you in the post-hoc subgroup analysis, those ones with the low EF benefited. Scott Solomon and the paradigm investigators now divided it in a different style. Less than 28, 28 to 33, and over 33. And we're able to show benefit with ARNI all across, regardless of the EF. So that's a little bit contradictory to the original paper. Now, from the academia, there has been interesting editorials. This is from Art Feldman, who actually, this is a sort of a opinion piece stating that we need to be aware of the wide spectrum of substrates the neprilysin inhibition could target, and especially call for attention to cognitive function, potential dementia, macular degeneration as important outcome measures that need to be collected. And there was a very similar paper that came from the European Society that got published, but these are all, of course, hypothesis generating and perhaps interesting, but without any data to support these. In the paradigm heart failure study, they didn't measure executive function, so there was not a mini-mental test score, but adverse effects or adverse SANEs related to sudden loss of memory or cognitive function were not higher. So that's what they are going to say. We didn't have ANEs or SANEs, serious adverse event rates, due to this, but they're very rare for these to be reported because these are chronic entities. And they also have the sponsor, the company apparently has a primate data, which is, I think, needing to be published. And they state that this is by their FDA submission, that the amyloid beta was not impaired in the primate data, and also in the CSF of normal volunteers, it was not altered. So that data is out there. But again, this is not clear as to the duration and the dose, and will need to be clarified. Now, the follow-up of paradigm heart failure was relatively short, and perhaps the dementia progression and macular degeneration may require a longer period of time, years, maybe decades, and may require the substrate, perhaps the aging or the predisposition to be in place. And the heart failure blood-brain barrier is different than the normal individual. So as to what would be the plaque progression and so forth will need to be discerned. And with these concerns, the FDA now requested from the company to put neurocognitive testing as well as imaging as potential outcome measures in a currently big trial, the HFpEF Paragon trial, that is going to monitor these patients for these outcomes, which I think is going to be very, very beneficial. So in summary, the unanswered questions include generalizability to real-world patients, because we have one study in mild to moderate heart failure. So we don't have data on very sick patients. And the other issue is there was a very artful run-in period, and whether the practitioners will be able to show the same discretion of that very, very delicate up-titration and backing off if the patient is not able to tolerate it. We've seen a similar story with aldo antagonism. It has a very, I think, important safety margin. And so one needs to be aware of this run-in period. And blood pressure, I think, is going to be an Achilles heel, because the study excluded hypotensive or even low borderline blood pressure patients twice, both in the screening phase and in the eventual randomization. So I think it's going to be important for us to recognize that the decrement in blood pressure is quite hefty. 14% of the patients actually had hypotension. And again, generalizability to certain racial background, 5% were Black, especially with the concerns for angioedema is concerning. Long-term impact, which we talked about, is going to be monitored, the amyloid deposition as well as cognitive function. And of course, the cost is a concern. It's a new agent that's quite costly, and I think that's a conservative estimate. And the methodology of enalapril being lower dose than what was the evidence perhaps target was, but not in reality eventually was received. So whether the difference would be so robust if the enalapril were to be given at a higher dose. And the more, I think, concrete questions that we don't have answers to are, should we switch patients who are stable on ACE inhibitors or ARBs to ARNIs? And the first-line therapy in ACE inhibitor naive patients should be the first-line therapy for our needs. And should we use, as the package insert implies, with a dose that has not been tried? What are we going to do with our battery of tests that we use in a variety of hospitals with BNP? Quite a significant proportion of the academic centers use BNP. We don't have currently either halting of the remodeling or reverse remodeling, which I think will need to be tested or seen, and other off-target effects that hasn't been even gaining the media attention or the trial attention, other than the perhaps the beta amyloid story and or the macular degeneration. I think there is definitely time-dependent effects, functionality effects of this NEP concept, and will need to be probably individualized according to patient. So with that, I will conclude my talk. I hope that I was able to give you a perspective, not an opinion piece, and I hope that I was able to represent it in an objective manner, not in a biased fashion. I realize it's a highly, targeted area now, gaining the perhaps the attention of the media, as well as the headline news, and as well as the focus of the guidelines. I'm going to be presenting on the same topic at the ACC, so it's going to be very similar to the flavor of what I'm going to be talking there about, and I hope that it was able to shed some light into the background for you. Any questions?